I'm very happy to introduce this panel. I'll be your moderator. My name is Dr. Carl Marci. I'm the Managing Director and Chief Psychiatrist for OM1's Mental Health and Neuroscience Division. And our topic today is what's AI got to do with it? It being a reference to treatment-resistant depression, obviously a shameless borrowing from the late great Tina Turner, and an attempt to get your attention. But it really is our topic today, where we are going to be discussing treatment-resistant depression from multiple perspectives that was inspired by a large research study that OM1 conducted in partnership with Compass Pathways. So my expert panelists, which I hope you will enjoy, involve three folks. So Dr. Steve Levine, who is the Senior Vice President of Patient Access and Medical Affairs for Compass Pathways. He is accompanied by Joseph Zabinski. Make sure I get the order right. He's our Managing Director for Artificial Intelligence and Personalized Medicine at OM1, and my partner there. And then last but certainly not least, Dr. Lisa Harding, who's an instructor of psychiatry at the Yale School of Medicine and a leader in the field of interventional psychiatry. So we're going to start off. I'm going to frame the study a little bit, and then I'll have the panelists introduce themselves. So the work I'm going to present to you is based on real-world data that OM1 houses and maintains. This particular data set comes from a large network of mental health patients across all 50 states. We have several million patients in our real-world data cloud in the psychiatry space. This is a particularly culled group of over 500,000 patients that are multi-source. And what I mean by that is the core of our data is electronic health records from mental health specialists. And then, as you can see, over 98% of them have linkage, deterministically linked to open claims that allow us to do some extra work. On average, we have over 7 years of follow-up. We have their medications, their doses, and then we have the clinical richness of those notes that we can use things like artificial intelligence and data science to extract clinically relevant information using our tools. And what we did was take that data set and attempt to ask it, if we take three different definitions of treatment-resistant depression, what kind of overlap do we get? Do we find the same patients, or do we see more of a diversity in terms of who we get into our funnel? So I'm going to walk you very briefly through the three different definitions we use. The first one we refer to as the regulatory definition. That's because this is the definition that FDA uses. A lot of payers use it. It's probably the most commonly cited definition in the research literature, and that is this notion that patients within a major depressive episode have failed 2 or more antidepressants of different type of an adequate dose and duration. Now that sounds easy to say. It's not the easiest thing to operationalize in a real-world data set. You have to make choices about what adequate duration is, what adequate dose is. You have to have good coverage. But we were able to do that with some confidence and pull those patients out. Importantly, there's no time constraint on that episode. So that major depressive episode is going to last as long as the medical record says it does. Our second definition came from the medical literature. This was published a number of years ago. It did also take an artificial intelligence machine learning approach to a real-world data set, but used a particular gold standard. And that gold standard was whether or not a patient had received an intervention such as transmagnetic stimulation, TMS, vagal nerve stimulation, or ECT, electroconvulsive therapy. Right? So these somatic therapies are really only used on patients, some of the more severe patients. So it was a pretty high bar. After a lot of analyses, the goal of this particular study was, could they create a simple definition that could be applied to real-world data sets? And they did at least achieve the simplicity. So 3 different antidepressants throughout the course of 1 year, or 1 antidepressant plus an antipsychotic as an augmentation therapy satisfied that definition. So you can sort of imagine the types of patients you're going to get there. Again, this is constrained by 1 year. And then the final definition we used, which Joe will talk about in a moment, is what we call patient finder or phenome. And this is the OM1 artificial intelligence model, which used a different gold standard here because we had the clinical notes from psychiatrists. we used an extraction technique that had string searches and fuzzy logic to find the phrase or the phrase equivalent of patient has treatment-resistant depression. So psychiatrists has actually documented, not saying they've had somatic therapies, doesn't matter how many antidepressants they've had, just someone wrote down, a psychiatrist wrote down in the chart, treatment-resistant depression. We flagged those and then built an AI model around that using all the data I referred to in that slide before. So what did we find? Well, overall, we found within about 500,000 patients, about 73,000, a little more, unique patients that were identified as having treatment-resistant depression by one of the three definitions. That gives us a prevalence of about 15%, which is right about the middle of the published prevalences between 5 and 30, 40%, depending on who you read. And what you can see here, however, this large bar, is that a large percentage of them, 83% or 61,000, only met one of those definitions. Only 16%, about 11,500, met two of the three definitions, and a very small number, 776 patients, or about 1%, actually met all three definitions. And if you look at that from an overlap analysis, a simple Venn diagram will show you a very small area where all three of them meet, and an awful lot of space where patients are falling into one definition but not another definition. So with that, I'm going to ask each of our panelists to say a little bit about themselves and to answer one question to get started. So Steve, I'm going to ask you to get started. Tell us a little bit about your role at Compass Pathways, and then why was this an important study for Compass Pathways to do?
Thanks, Carl. Good afternoon, everyone. So I'm Steve Levine. I lead patient access and medical affairs work with Compass. Why was this an important study for Compass? So in 1964, Supreme Court Justice Potter Stewart was asked for his test for obscenity, and his response famously was, "I know it when I see it." And so this means that treatment-resistant depression has at least one thing in common with pornography, because typically, this is how clinicians recognize treatment-resistant depression. They know it when they see it. And that's problematic in a number of ways. First of all, it typically results in clinicians recognizing TRD pretty late. Depending upon the definition used, typically a minimum threshold would be having been failed by at least 2 treatments within a current episode. With our phase 3 studies we're conducting right now with COMP360 psilocybin treatment, we're enrolling patients who've been failed by between 2 and 4 treatments within the current episode. But oftentimes in clinical practice, clinicians aren't recognizing patients with TRD until they've been failed by 5, 6, 10, 12 treatments. That's when they start to conceptualize these patients. Now that can be for a number of reasons. It can be because of the inconsistencies in the definitions, the lack of just one common standard, because they are infrequently measuring outcomes or using other rating scales to determine whether somebody is still currently within an episode, or are they now in having responded or in remission. But ultimately, the likelihood is that yes, they are recognizing TRD patients, but potentially much later than might be optimal, particularly given the implications for the recommendation of treatment once they've been identified to have treatment-resistant depression. This is particularly relevant from a manufacturer perspective because, as I'm sure many in this room are aware, the industry is beset and just plagued really by this history of failed programs in the neurosciences and specifically in depression programs. And that can be for a number of reasons, maybe because the endpoints are subjective or because there's historically very high placebo response rates, which makes it difficult to show separation of the active treatment. But also, of course, the standards for regulatory approval aren't the demonstration of safety, efficacy, and quality for just anyone, but in a defined population. And in a disease area where there is such inconsistency in the definition of that population, then that potentially is a challenge in terms of optimally identifying the population that should be enrolled in those trials and the demonstration of the efficacy for them. Ultimately, this is critically important to get right because someone dies of suicide every 40 seconds and tens of millions more live with mental health conditions for which there is no adequate standard of care at this point.
Yeah, and it's important to point out that there also is not a common definition of treatment-resistant depression, in part because it's not in the Diagnostic Statistical Manual of Diseases, and there's no diagnostic code for it, right? So another challenge, yet everybody talks about it, it's very common, and you all are developing a treatment for it, so that's great. So thank you. Joe, I'm going to go to you next. So you're the non-clinician, but the AI specialist on the panel. And talk to the folks here and everyone a little bit about what makes OM1's approach to AI and finding hard-to-find patients unique, and your thoughts on why things didn't overlap very well.
Yes, absolutely happy to comment on those. As you mentioned up front, I'm Joseph Zabinski, Managing Director of AI, very much not a clinician. But I've learned from these folks and from other clinicians in this field that there are particular reasons why psychiatry, the question of depression, is particularly usefully approached using AI generally, and I think the way that we approach it specifically. So a couple things to start out. First of all, it's important to understand this patient finder algorithm that Carl was describing is really using an AI-based digital phenotype to find patients. And what that means is we start off with this gold standard, this notion that we know some of these patients when we see them. And then we say, what is true in those patients' medical records prior to the moment that they walk into the psychiatrist's office, for example, that leads us to notice something similar among patients that clinicians are calling out in that way. So there's something about them that's common. That's why different psychiatrists will agree in many instances about the same patient being in a treatment-resistant state. And those commonalities in the patient's record can be found using AI and machine learning. So for example, prior treatment histories, experiences at the interplay between primary care and specialist care, other things that are going on in the patient's comorbid panel, for example, that can be related to their mental health. All of that sort of information is what AI technology is quite good at sort of extracting in a signaling way and then saying, when we see this stuff, it looks like it leads to a psychiatrist saying that this is a treatment-resistant patient. The reason that's really critical here is because we can't always ask a psychiatrist when we're looking at a data stream, is this a treatment-resistant patient, right? Of course, if any of you are evaluating the patient in your office, you can make an assessment, but that's not a scalable thing to do if we're sitting in our office looking at a data set of millions of people. This phenotyping technology lets us translate that sort of provider intuition into other things that are present in the data that we can then say, run the algorithm on 1 million people, give me the 100 that looks most similar to those that the psychiatrist had called out as TRD positive. It's particularly interesting, to do this because I like to think of it as, I think when we were doing development here, the clinical narratives we used to establish that patients had been called TRD by psychiatrists came from about 300 psychiatrists worth of information. So you're sort of like polling 300 psychiatrists to say, what do you all think are what TRD patients look like? And then the things that are held in common by those patients are what are extracted by the AI technology. A lot of AI models that you'll hear about are often built very much as point solutions. It's like predict this or identify that. This is saying there's something deeper. There's a deeper representation of what's true about these people, and that's different from other depression patients. And once we pull that out, I think of like a fingerprint. Once we've got that fingerprint in place, we can then go look for other patients in health systems or analyze data sets, which are both quite useful. To comment on the results part, which you asked me about, why don't those Venn diagram circles line up? I did not expect that. I don't know if any of us expected it. I think we expected sort of concentric rings, but more overlap. So I'll comment on, what does it mean that we identify patients using Patient Finder who don't fall in the other definitions? From the results of our study, and we can get into this in more detail, a lot of those patients, when you look at their files, they're patients who have been in, what we would think of as sort of like a hardened or a long-term, almost like a chronic treatment-resistant state. And it kind of makes sense that those patients look like that if you think about the other definitions, the ways they could have gotten into the other circles, right? There's an immediacy of recent treatment failure that gets you into those bubbles. But if you've been, suffering and without adequate treatment for years, you may not have an antipsychotic and an antidepressant within the past 12 months. You just may not, have that recent experience, or have this nice kind of laid out sequencing, as you were describing, Carl, of medication eras by which we can establish adequate dose and duration that's failed. Those people are real, and when I talk to any clinician, they'll say, yes, such and such patient that I'm thinking of fits that profile. Those are the people who end up in the patient finder bubble, who don't end up in the other bubbles. And this is true in other areas of application of this technology. A lot of the people that fall through clinical trial data or even real world data in a traditional analysis are elevatable by AI, and they're getting missed otherwise. So I think it's quite exciting to be able to find them. And something I've learned from all of you, I'll just say this last, treatment resistant doesn't mean that treatments don't exist, right? That's the promise of COMP360. That's the promise of lots of other things, both existing and coming in the pipeline. So I always think, getting these people highlighted and saying, here's somebody who is not in good shape, but who could be helped if we're able to point the spotlight to them, is quite useful. So I think that's what we were able to do.
Right, and one of the other opportunities of these models is potentially identifying folks earlier on in the course rather than waiting for a psychiatrist after they've failed multiple treatments.
That's right. Oftentimes these phenotypic fingerprints let us say, here's somebody who looks 80% familiar, similar to this.
Something last night about seeing 2,500 patients.
It's 4,000. Well, 2,500. So I have a treatment-resistant depression clinic, and so I do my own IVs. I do intravenous ketamine, Spravato, TMS, and before I decided to stop working in a basement, I used to do ECT at Yale, and so I've done about 4,000 procedures on patients myself. So I'm a clinician. My only claim to fame with AI is the fight I had with Alexa in the room upstairs. That's pretty much it. My view on AI is, anybody here watch college football, Nick Saban? So if you watch the Pat McAfee show, he talks about how he views where AI can fit into things and sort of like bringing back the human touch to it. I wanted to walk you through what happens so that they get the data sets to analyze them. So this is Joe, not our Joe, this is Joe Schmo. So Joe Schmo comes to see Dr. Lisa Harding, and how do I get, Joe Schmo to Joe Happy? And this is what generates the information that Joe can look at, actually, that our Joe can look at. So Joe Schmo comes to see me. I don't know if you know this, but disability in the United States is the leading cause of disability is major depressive disorder. And one of the hardest things is that post-pandemic, that number that you see up there is now risen to the top because all sorts of different forms of depression have come about, and we still have not classified them in the DSM. As Carl was saying earlier, it's pretty limited. So I use that DSM. Now it's a DSM-5 TR. I went to school for all these number of years. I see Joe. I try to fit Joe into a little box, and I'm thinking all these things. And by the way, if any of you have ever been to a doctor and the visit was more than 20 minutes, I'm doing all of these things in real time in 20 minutes. So I see Joe. Those are the only categories of depression that the DSM allows me to use. I have to stick him in one of these boxes despite everything else that's happening in his life, because at the end of the day, I have to get paid, I have to be reimbursed, so I have to pick something to put on his chart. So the APA as a psychiatrist gives me an algorithm. So after I've stuffed him into this little box, I then have to choose a treatment algorithm, whether this is his first episode of depression, whether he has comorbid anxiety, all of the treatments he has gone through. After that happens, I sit down because psychiatry is pretty rudimentary. If you pose this question to me, Carl, do I think treatment-resistant depression exists? I think it does and it doesn't. We stuff everything into a box based on the knowledge that we have now. By the treatments we have now, we have patients that are resistant to the treatments we have. So we have treatment-resistant patients. Years ago, we didn't even know that there was an orexin receptor, and now we have drugs that target that in the same fantastic work that Steve is doing with Compass. We have new targets. If those targets were were observed earlier and we intervened using those targets, would that person ever have even been resistant to depression? So as a clinician, I will tell you that it exists. As a scientist, to me, it does not, because the possibilities are limitless. Psychiatry is still in its rudimentary phases. We are now in the cool phases of what we do. So there's this thing called the biopsychosocial model, where I actually look at you and I say, hey, what's driving your depression? You hate your job? I could park up the ketamine truck outside your house. If you're still at that job, your depression is still 10 out of 10 and we're not doing anything with it. So these are the limitations. By the way, still in this 20-minute visit, I have to take all that knowledge in that Venn diagram and figure out which box you overlap in. And because of my clinical acumen, I can then say, oh, maybe this drug might work for this symptom. And I'm doing all that in real time. These treatments don't even reach our patients. There's a study by Lobloy in 2004 that said, for patients of color, minorities, whether if you're poor and white as well, this applies to you, physicians don't even consider a higher level of care for you because they don't think you're going to understand it and they don't think you can afford it. Then we come to the wonderful TRD clinical trial. Anybody with training in psychiatry knows that this is the most extensive clinical trial done with antidepressants in our country. So 4,000 patients, multi-site. Did you know that if you have a first episode of depression and you come to see me as your doctor, I say, hey, take fluoxetine. But the part that I don't tell you is that you have a 37% chance of getting better. Because me, I'd be like, wait, what? Mm-hmm. If you don't respond to that drug, then I move on to a second drug in the same category or give you some augmentation as per that protocol. And by the time we got to the third treatment, you had a 14% chance of getting better. I would look at you sideways, but this is what we've had to date. Then we had all these revolutions happen and we say, hey, now we're gonna test these second generation antipsychotics and we're gonna add them on to the medications we're using. I used to be an ER physician before I came to my senses and went back and became a psychiatrist. If you came into my ER with a gunshot wound and you were bleeding and I stitched that up and I said, you're about 60% bleeding, run along, it wouldn't be acceptable. Yet that's what we do in psychiatry. So we have these augmentation strategies that don't get our patients better, but we're telling ourselves that we're winning. Comes back to what Carl and Steve were both talking about at the beginning. We don't know the duration and the number of episodes patients have had. And we have the really cool treatments that I do. And then we come to, what is this costing us? This is the overall picture that got them to get the data that they have. I'm also a pessimist. One-on-one, I promise I'm more optimistic. So if you have questions, let me know.
Thank you. So when we look at the landscape here, obviously this is a complex picture, and this is the world of psychiatry. And I often say, if you would have told me, I'm a little older than you, in 2001 when I finished my training, that in 2021 I'd be practicing the same way, I would have said, no way, right? We're learning about the brain, there's all these new medications coming. I'm pretty much practicing the same way I did 20, 25 years ago. I think that might be about to change though, right? Steve, I think what's exciting about compass pathways, the psilocybins, ketamine, in whatever form you take it, whether it's Spravato or IM or now they're doing pills online, other novel mechanisms. So we think maybe are we on the cusp of a new renaissance in the treatment of depression? And do you think in my lifetime I'm going to have some new tools?
Well, perhaps, right? Over the past handful of years, we have finally seen some options approved that have a differentiated mechanism of action from what we've had for the past several decades. Starting back in the 1940s with tricyclics and MAOIs and moving through the SSRIs and SNRIs, lots and lots of drugs, lots and lots of names, but ultimately fairly little that differentiated them in terms of their mechanism. All essentially monoaminergic drugs modulating the levels of serotonin, dopamine, norepinephrine, perhaps some differences in terms of side effect profiles and so forth, but largely the same. And Lisa and Joe touched on this in some ways when we're trying to define treatment-resistant depression in terms of what we actually know. What we know is that these folks may be resistant to SSRIs or SNRIs, or at least monoaminergic approaches, but not necessarily that they may not benefit from new approaches, but they just haven't been available up until very recently. So yes, with the advent of newer approaches like ketamine and esketamine and TMS, Auvelity as a recent approval, we are finally seeing some new options with differentiated mechanisms. There are investigational products, including those from Compass and other manufacturers, that are also looking at different approaches. And this does potentially lead to some reclassification or rethinking about this population. First of all, these treatments do need to be studied in a specific population, because maybe it's true, maybe there is something different about people with treatment-resistant depression as far as how they respond pharmacokinetically or pharmacodynamically to a given drug. But again, maybe it's just that this is a group of people who aren't responsive to a particular approach, a particular mechanism. And I think the further development of new treatments not only will give patients new options, but potentially also teach us more about this population of patients and what TRD truly is.
Right, so going beyond serotonin and norepinephrine and adding glutamate and opiate receptors gives us a broader set of tools to actually approach patients. So then, Lisa, you put up that list of depression options from the DSM, and it's pretty short. Do we need to evolve our thinking to have more subtypes of depression as we get to a point where we have different tools? And is TRD really just a subtype of what you think of as major depressive disorder?
I think it all comes back to how we're taught. I think we use the DSM for something that was never intended to do. I'm a teacher, so I teach second-year residents and fourth-year residents that are coming up in their journey in psychiatry. We teach them how to classify and think of symptoms outside of individual symptoms and have a constellation of them to form a syndrome. So the classification, by definition, is to just aid in the thinking of how we classify it. Fast forward to now, our regulatory bodies have then taken our teaching tool and said, okay, we're now going to use this to make codes that are reimbursable for you to then go prove your work. And by proving the work is I have to put the patient in this little box, and then I attach that code to it, and then they give me a high five and a star and give me, $90 for doing a great job. And that's where we are. I think it's very, very limited. I think we don't even know what receptors are still out there. And beyond that definition, the other thing I didn't put on that slide were the specifiers. So you can have a major depressive disorder with an anxious distress as a subtype. And then there's another specifier for me to then grade the severity of it. It is extremely limited in terms of using it as a tool for a patient. None of it takes into account the socioeconomic status of a patient in that DSM. It doesn't allow you to categorize the symptoms or give an additional flair to what else is happening in that person's life. It's very, very limited.
Yeah, and Joe, then I always think of, we're in a time where artificial intelligence and data science are emergent. We now have these beautiful data sets we can apply them to. You and I have talked a little bit about what else we could do in terms of subtyping depression and maybe even getting to the point of predicting who's going to respond to what drug. Do you want to talk a little bit about that as a potential next step?
Yeah, absolutely. Those are exactly where my mind goes when you say, first-line treatment, 37% chance of responding. I mean, wouldn't it be useful to say this patient, they're 10% chance likelihood, this other one that walks in is 85% chance likelihood of response? That's the beginning of the kind of thing you can do as the next step here. Using, again, very similar process, right? As I was describing with identifying treatment-resistant depression, we start with a group of people that our expert clinicians have said are the group we're looking for. And then we say, what's the phenotype, the phenotypic expression, this fingerprint that corresponds to them. Here we would say, who's in the 37% and who's in the other 63%? And how are they different? How do those fingerprints look different? And then proactively, prospectively, does the new patient who walks in the office look more like A or B, right? That's kind of thing is absolutely happening now. Down the road from there, I think with this kind of blossoming of treatment options that's beginning to become true for the field now, there's even a next generation that says, is there truly sort of a sub-phenotypic expression that's better than just the 5 or the 10 boxes available, and that associates with treatment response. The first step, as you described, Carl, is to use these large enriched data sets to show there's things about the patient and those things correspond to response. And then to operationalize that to say, when the patient walks in, maybe you don't have to put them in a box, in a short list, but maybe you have a much more diverse set of options that you can customize and specialize to say, not just, these are the things I'm observing, but dynamically, how does that affect the options I have for treatment? And all of this stuff, I think if done right, plays very well with psychiatrists and with their expertise. It's not to go against it, but it's to augment, at a large scale, what we see in data, but at the point of care to say, here's some added information.
Right, we're not talking about replacing clinical judgment, we're talking about supplementing it or supporting decision-making with good data.
Right.
So Steve, Lisa is very passionate about access to care. I'm sure everybody in this room has read the newspaper over the last 3 years. The rates of increase in just about every major mental health disorder is going up faster than our ability to crank clinicians out. I read just the other day that zuranolone, the new medication for postpartum depression, is being priced at $16,000 for a two-week stretch, right? So, and COMP360 is going to hopefully be on the market soon, and there's a lot of psychotherapy to it. And how do you think about this potential of all these new medications and treatments? But if they get priced at a point where people can't access them, what are the implications of that? Or how do you think about that as someone who's talking to all kinds of people out there?
Yeah, it's a great question. I think about it from two perspectives. One is the cost to receive the treatment, and the other is the cost to deliver the treatment. And they're both important as it relates to access. As far as the cost to receive treatment, at least in the US, although we clearly don't have a perfect healthcare system, 91% of people are insured in some way, and most patients do depend upon their insurance benefits, whether it's commercial or government insurance, to accept, access, and afford their care. And it is the reason why we are approaching the development of COMP360 through a medical regulatory route for FDA approval and hopefully coverage by payers for broad and equitable access delivered within the existing healthcare system by appropriately licensed and trained clinicians. That means that it's covered, and at the patient level, it's a copay, right? And so, really that's, I think, the first part of patient affordability and accessibility is that development needs to progress through a route where it's something that a regulator can regulate and a payer can pay for. But then on the delivery side, you mentioned the cost of resources that can be involved in delivering this care, like psychological support, therapy, whatever that might be. And I think we have some lessons to learn there from the relatively recent launch of esketamine and the lack of codes required to describe the service delivery component, which was one of the stumbling blocks for the initial uptake of that new treatment. But also maybe not the greatest recognition early on of who would be involved in delivering that care, enabling people to practice to the top of their license, and therefore expanding the potential workforce as broadly as possible. Because while there may be a shortage overall of psychiatrists in this country, some might argue there's too many. This sweater vests, and we're not the easiest people to be around. But when it comes to delivering mental health care, there's certainly not enough. But the total mental health workforce is about 600,000 strong. So it's not that there aren't people to deliver care. And so I think we do need to think about who are the right people to be involved in the delivery of these new treatments, ensure that they're trained appropriately, and make sure that there's a reimbursement framework in place to ensure that they're adequately compensated.
So who's in that 600,000? Obviously, psychiatrists probably, around 30,000 or so?
Yes.
And what's the rest?
Yeah, and there's about 18,000 psychiatric nurse practitioners, a smaller number of physician's assistants. But then the numbers get bigger when you start to think about therapists, master's level clinicians like LCSWs, LPCs, family counselors, et cetera. They are in the hundreds of thousands. Mental health technicians, not to mention peer specialists, which are a group that right now aren't reimbursed through payers widely, but there's movement in that direction.
Lisa, you put up the biopsychosocial model, which is something that most psychiatrists are trained on. COMP360 the protocol includes built into it a lot of psychological support plus a biological molecule. In your world, in the real world, how do you think about the role of psychotherapy as a complement or substitute or augmentation itself to the medications you give patients?
It's funny because I think as the years go by, my opinions on everything change because we grow. I think we're all training in psychiatry, you learn how to do psychotherapy. And in the same way, believe it or not, I know this proliferation of all these mental health platforms make you think psychotherapy is just talking to somebody. Most people don't realize that there are different modalities of psychotherapy. So in the same way I can give you an SSRI, an SNRI, an NDRI, there's different types of psychotherapy as well. So there's psychodynamic psychotherapy, social rhythm psychotherapy, there's long-term psychoanalysis, and each one of them are specific for a different thing. I think in that biopsychosocial model, we absolutely cannot leave out psychotherapy. There is something about helping a person understand the biological underpinnings of their depression. It is a completely different thing to teach them new tools, because the way in which they're acting, the way in which they're interacting, sometimes is not helpful even with the best medications on board. Psychotherapy gives people insights not only to themselves, but that interaction with the world around them. That's a specific one, which is dialectic behavioral therapy, as you know. And the way it fits into this is that we really, it's a buzzword, but 360 wellness really includes everything that a person can do. In the world of treatment-resistant depression, however, I'll tell you, I don't think it can work. Most patients that meet me in a treatment-resistant depressive, or however you define that, they can't engage with anything. Our job for my subset of patients is to get them better where they can actually engage with the psychotherapy.
Yeah, and we were talking last night about this idea that maybe different medications can move patients to another stage, maybe not completely in a full remission, but to the stage where psychotherapy could start to work.
Absolutely.
But when you're at the point where you're so depressed and don't have motivation and lack insight, it might be hard to do that.
Yep.
Steve, do you want to add to that?
I can never add to Lisa.
Or at least we should be careful. Joe, to bring it back to artificial intelligence, right? So 2023 will be remembered as the year of the large language model and the year we all learned what generalized artificial intelligence is versus good old-fashioned AI. As you see the landscape, both through the lens of someone who applies AI to healthcare, but also beyond, should we be excited or scared?
That's a good question. It's a cop-out to say both. I think I would say excited, but people might disagree with me because some things might be scary. The reason I think this is exciting is because a lot of times if you're playing with ChatGPT or if you're reading the news stories about it, we highlight some of the craziest and strangest things that happen with the use of these tools. But like many other things, if used by people who know what they're doing in contexts where it's not the Wild West and we're trying to do something useful in our world in healthcare, they're quite powerful. They're not magic. A lot of the things you read about the flaws, specifically of generalized artificial intelligence, even relative to some of the older forms, are true. And we have to be on guard against that. But I think a lot of the anxieties come from, first, these things can appear quite opaque, right? People say like, this is a black box. I don't know what's going on. Generalized AI actually quite is a black box in a lot of cases, not always. We, as you know, Carl, we strive at OM1 to do white box AI modeling. And that's particularly useful when you're talking to patients because you can say, here are the things in your history that are pointing the needle in this direction or that direction on my risk calculator, for example.
That's amazing.
And the same thing, with the clinicians. We can speak to this tremendous knowledge of the pathway you described, Lisa, and say, here's how that lines up with what the algorithm is saying. That makes it less scary. And then the other thing is is the AI going to take over everything? It's going to start making all the decisions. We touched on this a little bit. I don't think that's a fear, especially in this kind of healthcare now, because we need the last mile clinical expert. That's not going to go away anytime soon.
Great. Yeah, and I think explainability is really important, right? And it's something that particularly in healthcare, you you want to be able to explain your intervention or how you're coming to your conclusions, and black boxes are very challenging for folks. So last question, and then we can open it up to the audience for questions. One of the challenges in psychiatry, mental health, brain science, and moving the needle forward has been the lack of biomarkers. And I'm curious, both Steve and Lisa, your point of view as you sort of think about, what we're able to do with AI. Is there a case to be made for a digital biomarker, that we can create sort of through big data signatures that begin to mirror a type of phenotype that patients are expressing and use that to predict things for patients? What do you think?
It's an overused expression, but of course, having biomarkers, digital or otherwise, is the holy grail of psychiatry. Forever we've had subjective endpoints. There have been some flashes in the pan over, various ones over decades that really haven't panned out as, predictive, helping to personalize treatment, as markers of treatment response, et cetera. So we still are very much wanting for more objective measures that help us select the right treatments for the right patient to identify whether somebody's responding, whether somebody's at risk of relapse, et cetera. We sorely need those. And so does AI represent that promise, or are there other digital biomarkers that may fill that need? Potentially. And I think that would, of course, be extremely useful to the field. I think there's, cautionary tales there as well. These people are complex, as we've identified over the course of this panel. The definitions that we have of these conditions are collections of symptoms that we draw circles around and give names of syndromes, but they're not highly specific. They're not diseases where we clearly know an etiology. And so I think it's unlikely that anytime soon we get to a biomarker that's 100% sensitive or specific. And in the absence of the true understanding of the etiology of diseases and having treatments that are curative for those, you potentially run the risk of using tools that maybe point you away from treatments for certain patients where we don't necessarily know whether that may not have been the right treatment for them. We may not quite be there yet. So I think that to Joe's point about we're not getting rid of the people anytime soon, at least for the last mile, for explainability or otherwise, potentially these are assistive tools at some point in the near future. But hopefully it does represent the potential of incremental progress towards better treatment selection.
Lisa, what do you think?
Well, I started off by saying I'm a pessimist, but in this case, I'm a skeptic, a pessimist, but I'm hopeful because I'm a teacher. So garbage in, garbage out. Has anybody here seen a surgical note after a hip replacement? Patient alive, NPO continue, and that's it. So the information you get is the information that you have to run these digital biomarkers off of. So what is the bias of the clinician putting in all of this information? We all know what the data on eyewitness accounts are for the court of law. Has there been an analysis of what clinician judgment superimposed on relaying that data that they have received into a clinical chart to be said in a way that's medical legally correct, that's protective of the patient, and that also gets them reimbursed? How true is that data set to what the patient is experiencing? And there comes my skepticism from it. My hope is that I teach residents to write notes. So we have you have the two extremes of patient alive, and then I have on the lovely Sunday morning, she came in wearing a lovely blue dress. So all the way from there to there, you're trying to extract that information. So I don't know, good luck.
No, I agree, and it's a challenge. Having read, now thousands of clinical notes from lots of different clinicians, the variability is off the charts. Although Joe teaches me that our models are pretty good at extracting sometimes very faint signals.
Well, you lay them over on top of each other, and the model's good at saying kind of what's the signal and what's the noise across all these providers. Yeah. And that's, a way of getting past these problems. But I will say the psychiatrists are wonderful relative to the orthopedic.
100%, yes.
Yes, in terms of the narrative and the richness. There's a lot to work with.
Well, I want to take a moment to thank our panelists, Lisa, Joe, and Steve. I really appreciate your time. And we can open up to questions if anybody has any in the audience. Don't be shy. Yes?
I love the last question, particularly because I just got back
So voice feature sort of extraction. Yeah, I mean, I think personally, to Lisa's point, you know, as wonderful as the medical record is and having lots of them helps, I don't think we'll truly get to a predictive model until we also tap into some of the sensing we're all wearing with us in our pockets, in our smartphones, which really fills in a lot of gaps between clinical visits and is really a terrific technology. So I appreciate the comment. I saw another hand up. Yes, sir.
Yeah, a question about the machine learning workflow that you use to derive the TRD score. Incorporated PHQ-9 as well as condition assessment.
Yeah, it's a good question. I'll let Joe give the more sophisticated answer, but you know, part of our process is iterative. So we're going to look across, often in this case, structured data, and he'll fill in some details. But what I like about our process is that at a certain point we sort of pause and have an expert review. So in this case, I come in and say, hey, do these signals, these features make sense? Is there a way in which we can cluster them together to make them make more sense? And invariably, the models get better, and then they're also more explainable. But talk about the different parts of the record we use, and do we use part of it? Do we use the whole thing?
Yeah, it's a great question. And in the interest of brevity, I'll say here we're using, as I mentioned at some point, I'd say the primary structured information in the patient's history. So we actually did not use things like PHQ-9 scores as part of the scoring algorithm. Sometimes we do use those kinds of assessments, but the problem with them is in many areas, including this one, you know, they're not often available in the real world as often as we like. And so making a model that invariably ends up depending on them a lot informationally limits the applicability. Mm-hmm. What we did here actually was look at correspondence between our assessing of patients' TRD likelihood and measured PHQ-9 scores that we did have. And then we looked at that as it corresponded to the literature and to, you know, the clinician experience of, you know, I guess my non-clinician way of saying it is, if the patient's feeling worse, does that mean that they're more likely to be in a treatment-resistant state? And there is literature to say that that's true. It seems obvious. I think the clinical narrative supports that. So sometimes we use it for confirmation in that way. Sometimes we do use it as part of the phenotype.
Yeah, and the odd thing about what we found, and we didn't put the slide up, but hopefully, Steve, when we write the paper, we can publish this. When you look at PHQ-9 scores against the pheno model, the AI model, it's a step function. So the higher probability of TRD, the higher your PHQ-9 score, the more depressed you are. When you look at the PHQ-9 scores relative to the regulatory model, there's no difference, right? So there's equal numbers of patients who have mild based on the PHQ-9 as they do severe, which makes you wonder a little bit about that definition clinically. Last question, yes?
Some thoughts, I guess, about TRD. So we're changing back, as you said, that it's patients that are currently resistant to treatments, right? But part of this AI processes still doesn't rescue those patients from going through those long trials and failures, basically. So going back to the idea to the beginning of trying to stratify patients. And another point that those that are really treatment-resistant probably commit suicide, unfortunately. So these are really good treatment-resistant and nothing that cool. So my point is to go back to maybe the effort is really to go in the beginning and do this AI to try to stratify and to take, well, omics, whatever else you can get additionally, and instead of just labeling people resistant, it's not having this prediction of what may be successful.
Good.
No, I think it's a great point. And I'm an optimist, so I'm going to answer this on an optimistic note, actually. You know, I think your point is well taken about the urgency of identifying these patients as early as possible, whether it's making predictions even before they might meet the criteria, but certainly as soon as possible when they might meet the criteria, whatever that criteria might be. You know, I think historically, and I'll speak as a psychiatrist here, and Lisa can argue with me as a psychiatrist if she disagrees, but I think there's been a sense of therapeutic nihilism on the part of psychiatrists that's maybe well earned. You know, Lisa referenced the TRD study, which showed us the woeful statistics of the likelihood of people benefiting from first and second line treatment prior to being considered TRD. And the tools that we've had for decades have been, reflected in STAR-D, have been modestly effective at best, take a very long time to work if they ever will, and of course come with a host of side effects as well. And so I think on the part of clinicians, psychiatrists and others, there hasn't necessarily been a reason to have a sense of urgency because there's, I think, not a lot of optimism that the next treatment will be any more effective than the current one and that the next treatment is really any different than the current one. That's changing, right? We do now have tools that can be more rapidly effective and potentially more effective in this population, and more in development. And so I think now more than ever, it's important that there is a sense of urgency in identifying these patients as rapidly as possible and getting them to treatments that have evidence that demonstrates that they may benefit at rates that they would not otherwise if they receive just the usual.
Thanks again to the panels. We can follow up after. Thank you for your attention. I
Yes.
appreciate everybody.
Thank you.